StarMed.
Hello, everybody. Welcome to this webinar, Thyroid RFA Case Review and Discussion. Thank you for spending some time with us today. My name is Brian Alexander, and I'm StarMed's Regional Manager for the U.S. I'm joined by Temu Medical's USA's Northeast Sales Manager, Jason Menzo.
And good evening to everybody, and appreciate you joining tonight.
We are excited to have doctors from various specialties talk about their experience, and we hope that the information being shared here today will help lead to better and improved outcomes for patients in the United States and abroad. Just a little housekeeping before we get started today. This webinar is estimated to take around 75 minutes, including questions and answers. The audience will be kept on mute during the webinar. Questions can be answered and submitted via the Q&A function at the bottom of your screen. After each case review, we will have a Q&A session, and then any remaining Q&As will be answered if time allows at the discussion at the end of the webinar. And this webinar will be recorded. So today's agenda, again, case review with Q&A at the end of each one, and then a discussion with all the speakers at the final parts. Without further ado, I'd like to introduce today's moderator, Professor Jung-Won Baek. Professor Baek is a radiologist and professor at the University of Ulsan College of Medicine in South Korea. He is dedicated to thyroid and head and neck imaging and intervention. He has established advanced diagnostic and interventional techniques for thyroid and neck diseases. He conducts the RMC training program of thyroid non-surgical treatments at Asan Medical Center, and he has published over 200 scientific papers and 7 book chapters. Professor Baek, welcome.
Thank you, Brian. Good afternoon and good morning, everyone. I welcome you all to this webinar. I am Dr. Baek from Asan Medical Center. It is my great honor to moderate the thyroid RF ablation session in this webinar. First of all, I appreciate Temu Medical and StarMed to organize this wonderful webinar. In this webinar, we invite the 4 speakers from United States. They will introduce very interesting cases today. So let me introduce first speaker, Dr. Michael Dweck. He's a radiologist in UCLA Medical Center, Santa Monica, California. Dr. Dweck, please.
Thank you, Dr. Baek, and good afternoon, good evening, good morning, depending on where you are. I'm just making sure, okay, I have my slides. So again, my name is Michael Dweck. I'm a radiologist, I'm from UCLA. Here are my disclosures. And before I start, I just wanted to thank StarMed, to thank Taiwan, to thank my co-panelists, and especially to thank Dr. Baek. I had an opportunity a couple years ago to visit Dr. Baek and his team at Asan Medical Center in Seoul, Korea. It was really a wonderful experience. I learned a lot. And since that time, Dr. Baek has been really very helpful in terms of consulting on some cases that I've had. So thank you, and thank you all, and thank you for inviting me to show a couple cases. I have a couple brief cases today. This is UCLA. This is the university and my hospital, one of the hospitals in the UCLA health system. And just a little bit about thermal ablation at UCLA. It's something that we've been doing for a lot longer than I've been there. For about 25 years, we've been doing thermal ablation, and it's a busy ablation program with roughly 500 to 600 ablations per year, the vast majority being in the liver, in the lung, and kidneys, with a smaller volume in other areas. And more recently, a small but growing volume, and we're happy to see that it's growing, in the thyroid gland and in the neck. We did our first thyroid thermal ablation approximately 6 years ago. And since then, we've done a small volume of thyroid nodules, some primary thyroid cancers, and also some recurrent cancers. My first case, a 50-year-old woman who presented with neck fullness, some trouble clearing her throat, and voice hoarseness. And she is Los Angeles. She's an actress. She's a singer, and this was interfering with her work. She had normal thyroid function tests and a biopsy-proven benign thyroid nodule 2 times. This is from her initial evaluation. This is her ultrasound examination. And what we can see is a multicentric, predominantly solid thyroid nodule that occupies much of the right and inferior thyroid lobe. The volume of this together was roughly 30 cc's. And I think this has been our experience. This actually is probably one of the smaller thyroid nodules that's referred to us. And it seems that the referral pattern in our institution is for nodules to be at a slightly bigger size than what's been reported in some of the literature. And I wanted to discuss today one approach that we've taken for this nodule and for others that are a larger size, and that is to approach this in a stepwise fashion. And so we divided this nodule into discrete parts. This first part, this paratracheal part, with a volume of about 5 cc. And then the inferior parts, and this is inferior isthmic components with both right and left crossing the midline, with combined volume of approximately 26 cc, so roughly a 30 cc nodule. And we prospectively decided that we would take this in a stepwise fashion, and if the patient could tolerate or we felt comfortable going further, we could always do this in fewer sessions than 3. But as it turned out, this was a 3-component ablation. She was ablated first that paratracheal, then the right inferior component, then the left inferior component in 3 sessions spaced roughly 1 to 2 months apart. And this is about 6 months post-ablation, where this is again a cine ultrasound image where we can see the character of the nodule has changed. It's more hypoechoic. I don't show it to you here, but the vascularity has diminished quite a bit. And let me show you the next slide if I can get this to move forward. Let me go back one. So that was at 6 months, and then more recently, we just saw her back in clinic October 2020, where there's been really a fairly dramatic decrease in the volume of this nodule. The first component, that paratracheal component, now has a volume of less than 0.2 cc. So this is a volume reduction ratio of 96%. And the inferior component, which had a volume of 26 cc, now has a volume of less than 2 cc. See, we seem to be stuck. Let me see if I can get this to move. There we go. So she did have a transient episode, we think, of subclinical hypothyroidism. She was treated very briefly with Synthroid with thyroid replacement for roughly 2 to 3 months, and then became hyperthyroid on the thyroid replacement. And so we took her off, and eventually her thyroid labs normalized. The nodule, which was cosmetically bothersome to her, was no longer visible, and all the symptoms, including the sensation of fullness and her voice hoarseness, have resolved at this point. My second case, this is an 89-year-old man. He's had a total thyroidectomy, and he's had a central neck dissection several years previously for papillary thyroid carcinoma. He also had radioactive iodine ablation, and recently he's had an increase, a slow increase in the thyroglobulin levels with negative thyroglobulin antibodies. And he was found to have a biopsy-proven isolated left level 3 nodal recurrence. Because of his advanced age, because of the multiple surgeries in his neck, and because of comorbidities, including cardiac issues, atrial fibrillation, aortic stenosis, etc., he was deemed not an operable candidate, and he was referred for ablation. This is that left level 3 lymph node, inseparable from the, not inseparable, but abutting the left internal jugular vein, which is sort of flattened here. And so this brings up the question of the nerves at risk during ablation. In this location, we know the vagus nerve runs in this area. We also worry about risk, of course, to the recurrent laryngeal nerve, but other nerves, we think about cervical sympathetic trunk, spinal accessory nerve, brachial plexus, and cervical plexus and its branches. And so in this case, this is in close proximity to the vagus nerve. And the vagus nerve, fortunately, we can usually see with ultrasound, as we do here. And in this nice article where Dr. Bake was one of the contributing authors, the typical location of the vagus nerve can be described by drawing intersecting vertical and horizontal lines through the carotid artery, and then oblique lines at 30 degrees from the vertical. And the vast majority of the time, as in this case, the vagus nerve will be on that lateral aspect of the carotid. 21% anteriorly, a small percent would be medial, and an even smaller percent posterior. Vagus nerve usually is well visualized, as we said, and usually can be well handled. And in this case, we're introducing D5 to try and separate the internal jugular vein and the lymph node at the medial aspect to protect the vagus nerve, and then at its posterior aspect to protect other nerves such as cervical sympathetic ganglia. When we've achieved sort of that optimal hydrodisplacement, hydroprotection, we can begin the ablation. And this proceeded quite quickly. This is done as an outpatient. This is done with local anesthesia. The patient had really no pain, no discomfort to this procedure. He tolerated it very well. This is immediately post-ablation. And then we've seen him recently. This is 3 months post-ablation, where we saw a volume reduction, about 40% volume reduction. His thyroid globulin levels have come down to less than 0.2. There's no vascular flow to this lymph node, compatible with a completely ablated lymph node. So those are my two cases. There's a few questions that these bring up that I'm hoping to pose to Dr. Bake or the other panelists, but I'm curious as to other strategies. I think Dr. Maya at the last thyroid webinar in October also showed a very large multicentric nodule that was also treated in this staged approach. And I think in our practice, we're finding that this is sometimes an optimal technique to make sure that we do this safely and to make sure that these larger nodules are treated entirely. In this case, we saw in that first case an incident, transient incidence of hypothyroidism. In most of our experience, we've not experienced this, but I'm curious as to others might have, or conversely hyperthyroidism. And then the second case, we follow these lymph nodes by morphology, by their size and by their vascular flow, but I've heard others talk about using contrast ultrasound, microvascular ultrasound to follow these sonographically as well. I'm curious if others have experience with that. And then sometimes in suspected recurrence, biopsy plays a role, but it brings up the question as to whether there's false cytologic results, false cytologic atypia that may be misleading after ablation. And then the final question I had is, this is another case referred to us recently of also an elderly man who's had multiple ablations, and we have a lymph node deep to the carotid bifurcation, deep to the internal jugular vein. I'm curious specifically for Dr. Bake if you might have any advice here, if this is something that you have any pointers on how to deal with this, or if we should deal with this at all. Thank you very much.
Thank you very much, Dr. Dui. Your two cases, in my opinion, the procedure was very, very excellent. First of all, I will give advice you for the question 5, means the recurrent cancer behind carotid sheath, very upper neck. You should carefully treat the tumor because of the hypoglossal lobe is very close to the tumor. Can you see the submandibular gland in front of the mass?
Yes. Yes.
Just medial to the SMG, submandibular gland, the sublingual gland go into the mouth floor. Be careful.
Thank you.
Yes, and in terms of a first case, I agree with your approach to Raji multinodular goiter, and hypothyroidism is usually less than 1% in our center, extremely rare, and the hyperthyroidism is more, more rare, very rare. And let me introduce questions from the audience. The first question is the first case, your first case, you used the lateral approach instead of transismic. Can you explain about that?
Yeah, I don't know. We typically do use a transismic approach. In this case, I just felt that we would get better coverage if we pursued a lateral approach rather than transismic approach, especially for those inferior components that were really there was no isthmus in those cases. They were quite low, and so just to ensure that we got as complete an ablation as possible, anatomically, we felt the lateral approach would give us a better shot at that.
Yes, I agree with you. If there is no enough amount of isthmus, I sometimes use a lateral approach. And the second question is what was the cause of voice problem in your case?
Voice problem? It was hoarseness. So was a professional actor and singer, and she was finding that she was hoarse while she was singing, which was really interfering with her work. So yeah, hoarseness.
Is there any technical problem in your procedure? Technical difficulty or problem?
No technical difficulty. Not with this case. No, it was very well tolerated. Went very smoothly.
And the other question is did you confirm the vocal cord examination?
Following the ablation, at each ablation, we visualize the vocal cords with ultrasound and make sure that they're still functioning. In addition, this patient is conversant throughout the procedure, so if we notice any voice changes, we would.
Laryngoscopy or ultrasound?
Ultrasound.
Ultrasound, okay. Ultrasound is, in my opinion, in our experience, ultrasound examination is very useful to evaluate vocal cord movement. And one question from the audience is alcohol ablation. Did you have experience with alcohol ablation for recurrent tumor? Maybe.
Yes, we do. Prior to the last few years, we used alcohol ablation in the neck with variable success. I think I feel that the thermal ablation, the radiofrequency ablation is a little bit more controllable. It's easier to visualize where you're going. There's less of an issue of extravasation outside of the solid lymph node in this case, and you have the benefit of the thermal protective effects of water of D5. So I prefer in this case to thermal ablation, although yes, we do have many years of experience with alcohol ablation, and in certain circumstances for very small nodules or for nodules that have predominantly cystic components, we still do use alcohol or sometimes a combination of the two modalities.
Yeah, thank you. We have a lot of questions from the audience, but it's time to move to next case. Next speaker is Dr. Tim Huber. He's an assistant professor and interventional radiologist in Oregon Health and Science University. He will introduce two interesting cases of RF ablation for benign thyroid nodules. Dr. Huber, please.
So I'm Dr. Huber, Timothy Huber, assistant professor at the Tyler Department of Interventional Radiology at OHSU. I did my fellowship training at University of Virginia and learned radiofrequency ablation from my mentor, Dr. Park, who works there. We started our program of thyroid ablation here at OHSU about July of 2020, just sort of at the end of the first wave of COVID. And we've been off to a pretty busy start here. A lot of patients very interested in it out here. I'll present 2 cases today from our early experience. Case 1, we have a 54-year-old female with a slowly enlarging nodule. She's had the nodule for about 5 years. Her thyroid function was normal. She did have a worsening foreign body sensation and pressure in the neck. She had some bulge that was sort of noticeable to her and cosmetically concerning, but no hoarseness. She did note that her foreign body sensation, the pressure, were worse when turning her head or extending the neck. That's something that I find with a lot of my patients who have these nodules. It can be a little difficult to localize symptoms and confirm if some of their symptoms are caused by the nodule or sort of overlapping sources, but oftentimes I find that provocative maneuvers like extending the neck or turning the head can sort of elicit a worsening of that symptoms. She had a history of a prior hemithyroidectomy for a benign nodule about 10 years earlier, and then also in the interval had a prior anterior cervical fusion. She really wanted to preserve her remaining thyroid gland, and she really wanted to avoid surgery. She'd had some really sort of bad complications after both surgeries, unfortunately, and was very hesitant to have another surgery. So pre-procedure, we check TSH and free T4 in everyone. We had a TSH of 2.3, which is normal. The volume of the nodule, you can see this spongiform nodule on the left side here. Was 3.4 by 2 by 2.2 centimeters. Volume was 7.8 cc's. Again, sort of very spongiform in appearance. So we performed FNA. We used a transismic approach here. This is the FNA before. We do 2 FNAs before we do our ablations. Both FNAs were Bethesda 3. In general, in our practice, we're following the KSAR 2017 guidelines, which recommends 2 ultrasound-guided FNAs or core needle biopsies before RFA. A single benign can be considered if the features of the nodule are highly specific for benignity, such as isoechoic spongiform nodules or partially cystic nodules. So pre-procedure imaging, again, we see the spongiform nodule. It has really no significant internal vascularity, some peripheral vessels. We do all these procedures with local anesthetic only. We don't do any moderate sedation or general anesthesia. So hydrodissection and numbing of the skin is very important for patient comfort and patient satisfaction. So we take a lot of time to make sure we numb the skin well, numbed all the way down to the thyroid capsule. Then we spend some time hydrodissecting with lidocaine along the anterior surface of the thyroid gland. I find often that you can sort of level out your needle and kind of advance it along the thyroid capsule and really get a good infiltration of the lidocaine, out to the lateral margin and anteriorly, and get it inferiorly, superiorly for really good coverage all around the nodule. Here you can see the bubble of lidocaine forming and extending out laterally. You can also see on this ultrasound the so-called danger triangle at the posterior medial margin of the thyroid. This is where the recurrent laryngeal nerve is, and an area important to identify and to be aware of during our procedure. Here we see the carotid, the internal jugular, also as Dr. Doug was just talking about, the vagus nerve, and being aware of the anatomy there. So approaching, we typically approach in the transismic approach, as Dr. Beck was speaking about. Here we're coming in medial to lateral to avoid that danger triangle and to stay well away from the recurrent laryngeal nerve. Here you can see our probe as deep into the nodule. You can see the tip is at the posterior lateral margin, and we start our ablation from that point. And then we proceed kind of fanning our ablation probe more anteriorly for coverage. You want to sort of work posterior to anterior so that we don't gas ourselves out with the cavitary bubbles that are forming during the ablation. And I typically work sort of inferior to superior in the nodule. Here you can see immediately after the procedure, there's really no more vascularity on the periphery. And we have a very nice heterogeneous appearance throughout the entire nodule, showing that it's well covered and well treated. Follow-up, so like I said, ours is a newish program. Our follow-up is really only 1 month at this point. For most patients, at 1 month, she came in and her symptoms had shown some subjective improvement. Her nodule had shrunk in size somewhat. It was measuring 2.8 by 1.8 by 1.9 centimeters. New volume was 5 cc's, so it had shrunk by about 36% on the reduction ratio there. We checked TSHs at our 1 month follow-up, and it was unchanged from pre-procedure. So you can see here again, the now very hypoechoic nodule, really with no internal or peripheral vascularity. So benign solid nodules with compressive symptoms, a lot of the nodules that we're treating currently in our practice fall into this category. Nodules are very common. By palpation, reportedly about 4 to 6% of the population will have them, but if you include autopsy or ultrasound, they're very, very common. 50, 60+ % of the population will be found to have them. They can cause compressive symptoms based on their size and their location. And their location will kind of dictate a little bit what the patients will present with. You know, more left-sided nodules posteriorly can compress against the esophagus and cause swallowing problems. Close to nerves can cause hoarseness. RFA is a great alternative to surgery. We're trying to promote this in our practice in Oregon. It's an outpatient procedure, no general anesthesia. We're trying to preserve the thyroid tissue. This outpatient and then no general anesthesia has been really important in the COVID setting and has really helped us, I think, with approvals for these patients to get the procedure done. Hydrodissection, I find, is a very important part of the procedure, making sure we have both sort of thermal protection, but then also adequate numbing of the capsule of the thyroid gland so that patients are comfortable throughout the procedure. Anatomic considerations, again, the danger triangle is a very important region to recognize for nerve protection. And that transisthmic approach allows you to come into the nodule in a way that avoids the danger triangle and will protect your patient. Size reduction, so a lot of patients will ask, what can I expect in terms of reduction in the size of the nodule? What should my post-procedure expectations really be? And so I typically reach for this paper. Again, Dr. Beck, co-author here, looking out to 4 years at volume reductions. And, I tell patients typically, in the first 6-month period, we're hoping to get, reductions here somewhere in the 70% range. By a year, we're hoping for closer to 90%, and then kind of a little bit more, maybe out past 1 year, but not significantly more. So I kind of give them a sense of what they're going to expect kind of 6 months and a year out. But it's important to make sure the patients understand it's going to be a somewhat slow process of involution. It's not an immediate relief of symptoms. So far, they've all been, that I've treated, have been very willing to wait, but just something to make sure they're aware of. So here you can see those reduction ratios. All right, case number 2, a younger patient, a 25-year-old female. She had about 3 years of anxiety, hair thinning and hair loss, and intermittent palpitations, and she was found to have a right-sided nodule incidentally about 2 years before presentation to us. More recently, she began to develop globus sensation and pressure in the neck as this nodule started to enlarge and presented to our thyroid and parathyroid clinic for repeat evaluation and second opinion. When she was referred to OHSU, her TSH was low at 0.25 and free T4 was 0.9. All consistent with subclinical hyperthyroidism. On ultrasound, she had an iso to hypoechoic nodule in the right lobe. You can see it here, ovoid, measuring 3.5 by 2.2 by 1.3 centimeters, volume of 5.2 cc's, and it was quite hypervascular on Doppler here. Commonly, these nodules will be a bit more hypervascular and have more peritumoral vascularity. The I-123 uptake scan was elevated, consistent with a functional nodule. She did have 2 biopsies and both were benign. You can see suppression in the rest of the thyroid gland, still some uptake, but relative suppression relative to the nodule, consistent with a hot nodule. So on a pre-procedure scan prior to ablation, again, you can see this isoechoic nodule, a fair amount of vascularity. Here we are looking in trans. Again, we can see the danger triangle here, deep to the thyroid gland. Again, carotid. And here we're sort of looking along the anterior capsule here, planning about how we're going to do this ablation. It's nice if you have a nice rim of thyroid tissue all around the nodule. It kind of protects the nodule from rupture and keeps it nicely contained. The thyroid capsule, I find, does a pretty good job of containing the nodule and preventing a nodule rupture. We actually haven't had a nodule rupture yet in our experience, but I also use hydrodissection here as well to kind of create a thermal buffer. So again, here we've hydrodissected around. You can see here our hydrodissection plane tracking along laterally to the thyroid capsule. Here we're treating now in more horizontal position the anterior portion of the nodule. And after treatment, we have good coverage of the nodule, quite heterogeneous in the center. At 1 month follow-up, we still see a few areas of potentially viable tumor along the periphery. Some of these areas I'm planning to keep an eye on. I'm not sure if a few of these areas may represent persistent tumor, but we'll see on her continued follow-up. It was diffusely heterogeneous. Most of the nodule appeared this sort of heterogeneous post-ablation appearance. The nodule had reduced in size down to about 3.7 cc's, and the ratio was about 30%. Her TSH was still low, and her T4 was still kind of the normal range, so still subclinical hypothyroidism. Her hyperthyroid symptoms hadn't really improved. Her subjective pressure symptoms had improved somewhat, so we'll see at her additional follow-up how she progresses. Autonomously functioning nodules are thyroid adenomas. They often have a mutated TSH receptor that's permanently activated, leading to their functional status. The thyroid gland can show variable patterns of uptake. In this case, it was diffusely suppressed. These nodules are often hypervascular, and the heat sink can make the margin challenging. RFA is notorious for heat sink susceptibility, and so that increased peritumoral vascularity can be a little bit difficult. I find that going around and taking some extra time to try to treat some of that peritumoral vascularity can help with your margin and prevent some of those marginal residual disease or marginal recurrence patients. Restoring euthyroid state. So one of her goals was to try to get her hyperthyroid symptoms under control. And the results are typically better for smaller functional nodules. 80% of patients will improve for nodules that are under 12 cc's. So typically, if you're trying to select good patients for this procedure, probably smaller functional nodules are better to go with. The volume reduction ratio, you want to shoot for a little bit more than you might otherwise. You want to be on the higher end, so at least 70 to 80% after 12 months to get these under control and to restore that euthyroid state. And so this is an ongoing area of research comparing to surgery. In our multidisciplinary group that we're discussing these cases with, there's still some debate with the surgeons about whether surgery or iodine is better to RFA, but hopefully we can convince them moving forward that this is really a better way to treat these nodules. Thank you. Any questions?
Thank you very much, Dr. Huber. So there is two questions, many questions from the audience, and here is important questions. What do you think about the RF ablation and the radioactive iodine therapy for your second case?
As a combination therapy, we have discussed
No. Comparing
the two.
Yeah.
Understand. So most of the patients that I've spoken with who are candidates for both favor RFA because it's thyroid preserving. It's not going to damage the thyroid gland like the radioactive iodine would. So I tend to recommend RFA for folks that have, they're younger, they want to preserve the thyroid function, and that's a major concern for them. Yes,
I agree with your opinion. First, the second patient shows a young female patient, 25-year-old. Mm-hmm. So RF ablation would be acceptable for this patient. Another question, what did you do 2 times of biopsy for toxic nodule?
So she had had one previously before she got to us. She hadn't really been worked up as fully at the outside. And then when she initially presented, the endocrinologist who saw her just reflexively got another FNA when she kind of came to his clinic.
Yes.
So that was sort of why. It was a little bit of we wouldn't have typically worked up quite that way probably, but that's just sort of how it came in the referral pattern.
Yeah, thank you. The guidelines suggest one time of biopsy for toxic nodule because the malignant risk of toxic nodule is very low. Thank you. And here is the technical questions. Did you use a vascular ablation technique for second case?
I did. Well, I attempted to as well as I could, and I spent extra time. And that's sort of what I was trying to show in one of those slides, trying to go in along a little more anteriorly, along the anterior margin of the nodule, and trying to ablate some of those peritumoral vessels during the ablation to get a more clean margin.
Yes, thank you. And this is another important question. What about the cytotoxic symptoms during ablation of toxic nodule?
Great question. So in the few nodules I've treated, I haven't experienced anybody have any thyrotoxicosis. The patient complained of a little bit of increased hair loss subjectively, she thought. So I saw her in clinic early. We rechecked her labs and nothing had changed. And her symptoms to me when I saw her really hadn't progressed any. So I'm not sure if that was real or more subjective.
Yes, the RF ablation can induce mild high cytotoxicosis during ablation, but it decreases rapidly. So usually the patient complained of no symptoms during or after ablation. If cytotoxicosis is severe, we can use beta blocker before and after ablation. We will skip similar questions. The next question is about the admission after RF ablation.
Admission, so we don't admit our patients. They're all outpatient, and we do their procedure in outpatient procedure center, and they go home same day.
Yes, we also do not admit patient. We use our outpatient clinic. Similar questions here. Do you use anti-thyroid drug for some days? Do you use?
We haven't been, no. If they are on methimazole kind of pre-procedure, we'll keep them on and follow them closely and follow their thyroid and their TFT levels afterwards and adjust as needed, but not routinely if they aren't on them beforehand.
Yeah. Yes, thank you. We don't use anti-thyroid drug. If necessary, we use a small amount of a beta blocker. And here is answer for previous question. No data directly comparing RAI and RF ablation, but patient with RFA will have less than very rare risk of hypothyroidism, but radioactive iodine therapy can induce hypothyroidism as time goes. That is why we use RF ablation, especially for young patients. Thank you. A lot of questions. Sorry. We have no time, so let's move on to the next topic. Next cases will be introduced by Dr. Imad Kender. He's an endocrine surgeon, professor, and chair in surgery of Tulane University, New Orleans. Dr. Kendall, please.
Well, thank you again for the invite. I believe now I'm the first surgeon to be on the panel, or actually the only surgeon on the panel, and I am speaking after two interventional radiologists. So I would like to mention that, for me, ultrasound is basically as an important tool for me to perform surgery. So it's really part of my exams, basically replace my physical examination most of the time. So I do have ultrasound, my practice, I have two ultrasound machines, two ultrasound rooms where I do a full ultrasound exam, and It's just an essential part of my practice. So I have
Thyroid when it comes to pancreas, they're telling me they can't provide coverage.
I think we found the product.
Big man here. We don't need you.
Everything about this. I also ultrasound patients in the OR. So just ultrasound is something that I believe surgeons should feel very comfortable with. And that's why I was able to catch up with this quickly. So I have significant interest in ablation in general. This is a paper that I published over 10 years ago looking at meta-analysis for ethanol injection. And we show this efficacy in aggressive recurrent thyroid cancer. And clearly, in general, ethanol ablation is effective in treating thyroid nodules, but was a little bit disappointing in solid nodules. This is what most of the literature show. So I did have significant experience with ethanol ablation before, and this is a paper that we just published recently. And what we showed here that elastography can predict outcome with ethanol ablation. So if you have a softer nodule, the volume reduction rate is expected to be significantly higher than a solid nodule or stiff nodule. So here's our training experience comparing radiofrequency ablation with ethanol ablation. I performed, I guess this month I was able to complete over 100 cases with the radiofrequency ablation. And I noticed in my own experience significant increased rate in the volume reduction percentage in general and the first follow-up. And then 6 months, you can see the data here. The p-value is significant with radiofrequency ablation in my own practice and the patient that I see here in New Orleans. And again, more data to show the significant change and volume reduction rate and radiofrequency ablation compared to ethanol in my own population. This is here a list of responses to radiofrequency ablation, but I'm going to move on to the case that I would like to mention. So I'm not going to go into details, but basically this is an 84-year-old gentleman who has been maxed on methimazole by his endocrinologist, and his TSH continued to be undetectable. So 84, multiple medical problems, including atrial fibrillation, and not candidate for surgery, no interest in surgery. So he was referred to me for possibly considering the radiofrequency ablation. As you can see here, I offered him this procedure. First time I saw him at the baseline in August, and you can see the volume. And 3 months after the ablation, I had 68% volume reduction rate. What's really more important that the patient came to me because of the hyperthyroidism, and his TSH went up to 14 from being undetectable. With follow-up though, the TSH started to normalize and has been normal now, and has been, I believe now over a year, but I need to see him soon, but so far did not need to be in any thyroid medication. We started on thyroid medication and that was tapered, and we'll follow up on that. So if you look at the literature, there's actually a recent paper that we just published looking at with systematic review and meta-analysis looking at RFA and autonomous functional thyroid nodules. And obviously you can see here in the table, Dr. Bake experience and Italian experience, but the normalization of the TSH was ranging from the 20% up to 80%, but at least they average over the 50%. And the volume reduction rate was significant, as you can see here. I mean, I've done 2 so far. We are writing a small series with Johns Hopkins. They have experience with 1 case too. And the idea is that it's all about expectation. And I think the patient will be very happy, for example, to consider a repeat RFA and instead of undergoing surgery, specifically if they are very high risk patients. Again, just looking at the data showing that the efficacy of this. I was asked to maybe discuss 5 questions, but basically always people ask if this should be done in the office or in the operating room. So I honestly believe that this can be done in the office. However, I mean, I do them as an outpatient, obviously, but in US, we have to follow certain guidelines with our hospitals. So I was asked to do this in the OR because this is how they cover for their cost. but literally I don't do anything fancy in the OR, maybe just a little versed, but other than that, I still want the patient to be awake and talking to the patient while performing the procedure. I'm aware that, you know, you know, Dr. Catherine St. Clair in Mount Sinai like to intubate patient to do the laryngeal adductor reflex sonography for the nerves. I think it's a little bit too much in my opinion, but I would love to do these basically simply in the office, but I do them in the OR for just logistic reasons. I think in cases when you have bilateral nodules, you really need to have a plan for staging. I'm very impressed with the first lecture talking about the staging approaches. I think the more you do of these cases, the less you do. You try to be more careful, making sure you don't cause any complications or any injuries. You know, it's interesting, the approach that was mentioned earlier by my colleague about the staging is different approaches. So my Brazilian friend and who does this also on team pages, he was telling me he does the upper part, try to shrink it, and he just do it again, basically try to shrink it from above. I don't do staging for nodule, but I really think you should not do two nodules at the same time. You know, through the cases, there were discussions about the nerve monitoring and the nerve injury. I believe you need to really have a good evaluation of the vocal cords. And if the patient, for example, have a recurrent laryngeal nerve on one side, you need to really think significantly before going to the other side with an ablation, because if you even get a temporary paresis, thermal paresis, this patient will require possibly a trach, and you don't want to go through this with any of our patients. And if you do it, having said that, I just did one, but you need to be very careful and not aggressive maybe in these cases. I believe though there was a question about evaluation of the vocal cords. I wrote a couple of papers about this. Ultrasound is definitely a good modality to evaluate the vocal cords, absolutely. However, what I found in our experience doing over 1,000 cases of these prospectively, that in obese patients, it might be a little bit tricky with the ultrasound. Also in males with the prominent larynx, it could be tricky. So I feel like the Asian data on Asian population is more accurate because they have definitely thinner population. But in our American population, obesity is usually not a friend with the ultrasound. So we got to be very careful with that when we do the ultrasound. I think a vocal cord evaluation with laryngoscopy is considered the standard of care, and you want to be really confident before doing these. For hydrodissection and local anesthesia, I think with time, I started with the transesmic approach and started with the local anesthesia and hydrodissection. But I started to feel the hydrodissection and all this is very good, and the anesthesia, if you have a nodule really at the capsule, because you want to really stay away from the strap muscle and subcutaneous tissue and avoid any thermal injury to this area, very sensitive area. But if the nodule is in the middle of the thyroid, I feel that the hydrodissection can make it a little bit more challenging because you push the nodule really more inferior. So I stopped doing these if the nodule is literally in the middle of the thyroid, and it just makes operation significantly faster. In my experience, many of these procedures routinely done under 5 minutes. I know Dr. Big does these very fast all the time. He's a master, but I really can do these quickly, routinely, every single time, like in a couple of minutes. Again, for transesmic versus short axis or lateral axis approach, I just feel the most important thing is just to make sure that you stay away from the dangerous triangle. And again, just not to be very aggressive and ending with a thermal injury. So you can do this, in my opinion, with either approach, as long as you are staying away from the dangerous triangle. And I've been doing more and more of the short axis approach. My own experience, I understand Dr. Bick is the master, and he's the one who proposed the transesmic, and I think it's an excellent approach. But I found that in my experience, with an average over 50% volume reduction rate after the first month, it's very good results so far with the number of patients that I've done with over 100 cases, and it's just a quick approach. Thank you very much. I'm happy to answer any questions.
Thank you very much, Dr. Kender. Your questions and considerations are very informative. May I invite our speakers to answer the questions, if we have any answers? No?
I would like to hear from our speakers if they would do a bilateral nodules.
Bilateral?
Yeah.
Oh, well, what about the team, Huber?
So we occasionally will treat multiple nodules on the same side, but we avoid doing bilateral nodules in the same session for the risks you guys just mentioned.
Same. Yes, I agree with the staging approach for multiple nodules. It is safe and comfortable for patient.
You know what? I have to say something. I've done last week a case where the patient had 2 large nodules and he's from far away, driving like long distance from Florida, out of state and all this. And he really asked me to do the 2 nodules. I said, okay, I'll do it. I'll be careful. I actually do a vocal cord exam right after the procedure with the laryngoscope routine in my practice. But anyway, so the vocal cords were fine, but the patient was a little like he noticed some hoarseness. So despite that the vocal cord exam is fine, I think if we do like a full exam with stroboscopy, we might find something subtle. So I'm just, after all this experience, I'm going back to just insist that we should not do bilateral nodules. And Dr. Baker is always right. So do not do bilateral nodules.
Okay, maybe your skill is very nice. And there is one question from
I would not do bilateral nodules anymore.
from the audience. Do you have experience with the surgery after RF ablation? Surgery. There is no surgeon. The question means maybe any kinds of complication for surgery. In the previous publications, RF ablation is usually achieved inside the thyroid gland and thyroid nodules. So the fibrosis or any kind of bleeding is very rare. So surgery was no problem.
So
Almost all cases, yeah.
So I did talk to some of my friends, Korean surgeons who have experience with this, because you guys have a very busy practice in Korea. So I do not have any experience with this so far. However, I've been told that they found it a little bit, some adhesions and stuff like this, and they try not to go back before 6 months. I think it's an intervention. Again, that's not my opinion. This is the opinion of a couple of my Korean friends who perform some of these operations.
Thank you. And Kender, do you have experience of RF ablation after non-successful retinal ablation?
So I did that, but I don't have the data yet. So I have to look at it. I had patient where I did ethanol and the results were non-impressive. It grew back, it has a recurrence. So I offer them RFA, but I don't have the data. So next time I'll come back with the data.
Any other doctors? Dr. Hodak or team? Do you have experience?
We haven't started malignancy yet, so we don't have any experience with much ethanol. We've done a few ethanol ablations of cysts. You know, they recur from time to time, and so we'll pre-treat with RFA when they recur after an ethanol ablation, but no malignancy yet.
Yeah, we've also done ethanol, but I haven't had any experience treating a nodule that's been treated previously with ethanol with radiofrequency ablation.
Yes, I have also have several patients with previous ethanol ablation, but RF ablation was successful, no problem.
The one case I showed has had, the last case that I had a question has had multiple ethanol ablations and they've recurred, and we're now considering radiofrequency ablation, but we've never done one yet. We might be doing this one.
Here is one technical questions. What do you think about the lateral approach? Lateral. And Dr. Huber, you used lateral approach?
We typically use transismic. We tend to avoid the lateral, but I have used it a few times.
Yeah.
If you can see your needle tip very well and you're confident in your skills, I think you can use it safely, but you have to have very good ultrasound skills and be very sure where your tip is before you start ablating.
Thank you. I also prefer transseismic approach, and lateral approach is very limited. In case of heavy calcification, at the root of ismic approach, I use lateral approach instead of transseismic approach method.
Good to know that you use it sometimes. That's good.
Yeah.
Excellent.
The question is, what is the largest size of nodule that you can consider RF ablation? Can you?
Actually, the larger it is, the more, the better I feel. Like I feel I can offer more to this patient. So I don't think there is really a limitation. But I'm really interested in the staging approach that Dr. Duke mentioned, and I think it's something, I like it because it's just safe.
Yeah, it's something that we've gotten referrals initially with, there were 80 cc's, 100 cc's, and they were very intimidating nodules. And we found sometimes when we tried to do too much, patients had difficulty tolerating it for these larger nodules. And I think more recently we've been, for larger nodules, more actively pursuing this staged approach. And if you do, then I don't know that there's an upper limit to how big you can get. I think as long as you just don't try and do too much at once, you can safely get through it. And it takes a patient that's willing to go through multiple sessions. But
I have to tell you, like in surgery, guidelines are changing. So for example, we used to do all the time like certain operation total thyroidectomy, but now in our guidelines now, if you do one side and for any reason the nerve is a little weak with your nerve monitoring or you're uncomfortable, the standard of care is to stop and plan a staging and come back later after making sure that everything's okay. So I think safety is going more and more into our planning and practice, and I think we should be very careful about this. As I mentioned earlier, over my experience with over 100 cases, I had one patient with a vocal cord paresis that was 3 months, was a pilot, and was a really painful experience to deal with. I just went crazy on him. I had like over 90% volume reduction rate, but I learned not to burn too much, I guess. So I guess the more you burn, you're really increasing the risk, even if you think you're away from the dangerous triangle and all this, but I think staging is good in these ideas. I think I'm going to plan to start to do this from here on. I don't want to deal with any paresis or any paralysis, absolutely.
Yes. And finally, here is an answer from the audience for surgery. The publication shows surgery after RFA without any concern. I agree with this opinion. Sometimes there is some adhesion, but our surgeon also mentioned that there was no problem for completion of surgery. So thank you very much, Dr. Kender. So we will move to final topic. Final topic will be discussed by Dr. Stephen Hodak. He's an endocrinologist in NIU Langone Medical Center, New York, from New York. So he will introduce 2 cases of thyroid ablation. Dr. Hodak, please.
Thank you, Dr. Beck, and thank you to my colleagues from other institutions who've joined the call tonight. It's a pleasure to be on this call with you. Okay. I'll present one case just because I think it makes a very nice visual. This is a 66-year-old woman who had a cosmetically bothersome nodule. You can see above the image that the nodule measured 34 by 24 by 35 milliliters. It was 15 milliliters in volume. She doesn't like the way it looks, and it was obvious why. It did not cause much in the way of mass effect. It had been previously biopsied and was benign twice. She had normal thyroid function and no risk factors for thyroid cancer. This is post-RFA, the nodule. This is about 6 months later. The nodule measures 30 by 20 by 24 at this point and had reduced in size to 7.2 milliliters, which was a change of almost 60% in 6 months. And you can also see the change in the appearance of the nodule, where the pre-ablation ultrasound shows the nodule was heterogeneous, more hypoechoic, and very solid. I think you can appreciate in the ultrasound cine clip on the right side of the screen that the nodule is now more hypoechoic, more heterogeneous, and is demonstrating evidence of undergoing degeneration. She noted a visible decrease in size within 2 weeks of the procedure. And she reported that the size continued to decrease over the next several months. Her friends and family also noticed the change. She noticed also markedly less neck tightness, which she wasn't aware that she was having in the past, probably because she'd had this nodule for so long and her thyroid function remains normal. So just a good example case. We talked a little bit about patients with unstable airways, and this is exactly that. A 66-year-old Asian woman who has an unstable airway, probably dating back to a benign partial thyroidectomy that she had in lobectomy that she had in China in the 1990s. She subsequently underwent bilateral lung transplantation in 2011 because of pulmonary fibrosis. She was hypothyroid and chronically on stable thyroid replacement. But in the course of her follow-up, she was noted to have a 12 millimeter biopsy proven left thyroid papillary thyroid cancer. She underwent direct laryngoscopy to assess her vocal cord function, and she was found to have complete paralysis of the right recurrent nerve with complete adduction of the right vocal fold, as well as partial paralysis of the left recurrent nerve with a nearly completely adducted left vocal fold. So a very tenuous airway. Surgery was not a good option for her. She was placed under observation and the papillary cancer was stable for several years of follow-up. But she then developed renal failure, probably due to a combination of diabetes and transplant medications, and required kidney transplant, but she could not be listed with an active malignancy. The surgeons basically were very, very hesitant to consider any sort of surgery because of the airway and the existing recurrent nerve paralysis. She was a very high risk for tracheostomy. She refused to have a tracheostomy and she refused surgery. So the only real option that was left was radiofrequency ablation, which we did. So this is a cine clip, if I can get the image started on the left, of the cancer, which is here. Sorry, having trouble with the slides. Can I go back one slide? It doesn't seem to let me. There we go. So the cancer is here. The medial aspect of the thyroid gland, you can see this very hypoechoic, irregularly bordered 14 by 8 by 15 millimeter nodule with sort of spiculated margins, microcalcifications. After radiofrequency ablation 6 months later, with a similar aspect, you can see the treated area here. It's actually larger than the original lesion. This was no doubt due to the fact that when I treated this, I treated a very aggressive margin around the nodule, but she then had multiple fine needle aspirations all throughout the treated area, and it showed no viable cells. There was no papillary cancer, and it was only some stromal cells and degenerated cellular material. So we were confident saying that this tumor had been extirpated by radiofrequency ablation. So a couple of questions about this case is, how common is it that there's very little size change of papillary cancer after radiofrequency ablation? I think in this case, as I said, I was aggressive about treating a wide margin around the tumor, and that may explain some of the observation of lack of resolution. And just a provocative question, should radiofrequency ablation be more frequently considered for small intrathyroidal papillary cancers instead of active surveillance? I would point out the data from Memorial Sloan Kettering, and there's similar data from Asia showing that progression occurs in somewhere between 13 to almost 20% of US patients in the age groups of 20 to 50, and they'll fail observation due to size change or very rare cases of lymph node metastasis developing. So perhaps in these younger patients, especially where there's a high rate of progression, more definitive therapy with RF ablation would be feasible. Okay, and just the last case. This is a 56-year-old woman with a thin neck and a big nodule, and you can see the nodule here in the right isthmus extending into the right isthmus junction. This is a solid, heterogeneous, and vascular nodule that measured 32 by 11 by 29 millimeters in 2020. And it had increased in size from 17 by 8 by 18 millimeters since observation in 2016. She's asymptomatic, but this nodule is cosmetically bothersome. It really protrudes from her neck. She's been completely averse to surgical management, and she's had now 3 biopsies of this nodule, starting in 2016 when it was read as Bethesda 3 Hürthle cell type. At the time, the molecular diagnostic test that we did was the version 2 of ThyroSeq. It was negative. I repeated that in 2017 because we had access to the updated ThyroSeq version 3. It was read as Bethesda 3 with Hürthle cell features again negative. And in 2019, it was rebiopsied with the idea that we were going to do some additional molecular diagnostic testing, but it was benign. It was read as a Hürthle cell hyperplastic nodule with a background of lymphocytic thyroiditis. So she's still very interested in radiofrequency ablation. She refuses surgery. The discussion I had with her was that I was going to do another FNA and this time offer the Affirma test, specifically because the Affirma still biases toward overcalling benign Hürthle cell nodules suspicious. And I felt that if the Affirma was also negative, this would be a reasonable target for radiofrequency ablation. So the questions for Dr. Beck and the panel is, do you agree that radiofrequency ablation in this nodule would be reasonable? First of all, based on the cytology, its enlargement over time, and its appearance, would proximity to the trachea be likely to make this an uncomfortable procedure for the patient during RF ablation? And would you attempt to infiltrate lidocaine posterior to the nodule around the trachea? And then there have been a couple of questions throughout the presentation about hydrodissection. I thought this would be an interesting issue to bring up relative to this case, because I think hydrodissection could be useful in lifting the nodule off the trachea. And I would just be curious if the panel would discuss their approaches to hydrodissection and how they do it.
Thank you very much, Hodak. You presented very interesting case and informative questions. Would you please show the last slide, Hodak's questions? Okay. And no. Previous slide, yes. And I would like to give open questions for all speakers about this.
I like your idea of the Affirma testing. We've done that a few times with some sort of equivocal FNA results that we're not totally sure about, and it's helped some troubleshooting for us in the past.
I think for the purposes of discussion, if whoever has control of the screen could just advance the Cine clip, we can see the nodule.
So, so there is different doctor who diagnose this. Like there are different tests. I don't want to just any genetic testing. It can be the Afirma testing. It can be the Interpace. It can be the Thyroid testing. I think it's appropriate to do it to get more information. However, I have to mention though, I had a couple of patients that had these tests that showed, for example, 40% malignancy rate. And the patient was telling me, well, listen, it's 40% risk of malignancy. I still have at least 60% is benign. I don't want to do surgery. And these like very intelligent people who have, great careers, and they're very intelligent people. They're like, we're not sure it's cancer. I want to ablate it. I saw that there is data to ablate cancer. Why we are not doing this? So I did ablate these even if the gene testing showed a risk of malignancy. I mean, most of the time, the gene test will either tell you 5% risk or 40%. Obviously, in some cases, it can be 75, or I just had 199%. But I think it's important to discuss these details with the patients. But I think it's a good idea either way to get more idea about this. I feel more comfortable if the gene testing is benign. That's number one. I think this is a perfect case for hydrodissection because it's very close to the strap muscles. And this is when you really can have significant inflammation of the strap or the subcutaneous tissue from the thermal ablation. So this is the case that I will really make sure I do a good hydrodissection. The posterior hydrodissection I don't have experience with, but I think it's a good idea. I never tried it, but I might want to try it in a case like this. But again, the key is to stay away from the dangerous triangle. And honestly, for me, this is a little bit from the dangerous triangle. The dangerous triangle is a little lower. This is more upper and the isthmus and the upper pool area. So it's kind of far from the nerve. But at any event, I'll stay a little bit from the inferior part. That's it. I think I covered the questions.
Oh, okay. Nice opinion.
I was gonna say I did have a primary PTC that was near the trachea, similar position, and we did attempt deeper hydrodisplacement without a ton of success. We were able to put the needle there, we were able to inject, but we didn't see any distance. We couldn't achieve any real distance. But nonetheless, I think it was reassuring to have a very thin layer of fluid between there. And we actively sort of pushed D5 very gently while we were ablating, just there's no science necessarily behind it, but just in the thought that perhaps just that thin layer might protect, even though there was no physical distancing there.
In the spirit of a stepwise approach, you could consider sort of undertreating that part near the trachea and treat the rest of the nodule, see how it looks on follow-up, and then retreat as necessary.
Thank you. And here is an interesting question from the audience. Which is the ideal specialty to perform RF ablation? Radiologist, surgeon, endocrinologist?
Who has the steadier hand?
I think honestly we should all work together on this. Should be a multidisciplinary approach, and we should all work together. I don't think it should be like a one specialty thing. But if the surgeon, for example, is not comfortable with the ultrasound, they should not be doing this. And also, if the radiologists do not do ultrasound biopsies and they are not doing these procedures, they should not be doing this. The same for endocrinologists. I really think this is something for someone who does biopsies on a routine basis and very comfortable with this. So it doesn't matter who does it as long as they're very good with the biopsies.
I would just expand on that, because my experience has been that even in the hands of an experienced surgeon, an experienced endocrinologist that does a lot of procedures, there's a surprising amount of practice that you need to have before you're really technically able to do these cases well. I would love to do a study to see how people's skill improves over time with practice, but I think practice is very important, and anyone who's getting into this in the early setting should really not underestimate the importance of practicing on phantoms before you actually try to work on a patient.
So we prospectively collected the data with time. I'm happy to work with anyone to look into that. Yeah.
I agree with your opinion. The doctor who is good at ultrasound should do this procedure, rather than specialty. And I have one more open questions for speakers. The Dr. Hodak already suggested PTMC. For PTMC patient, which is better, the RF ablation versus active surveillance?
I have a full lecture about this topic. I really think until today, we do not have data to tell us which nodules will progress and which nodules will not progress. As simple as this, there's a 70% progression rate in patients in the 20s. If a patient is a female or who become pregnant, there is 45% chance that this will progress. We really do not know anything about which nodules will progress and which nodules will not. Until we have a genetic panel that can tell us which one progress and which one not, I think RFA is the answer. But hopefully one day we might be able to identify a panel that can tell us which nodules will progress and which one not.
Any other opinion? It is true, evidence is not definite so far. Any other opinion? No? So let me introduce another questions from the audience. The question is RF ablation in pediatric patient. Do you have experience?
Can you repeat the question? In what patients?
Pediatric patient, pediatric. So we published this small population study for pediatric patients. So the result was similar to adult one. Any opinion? No?
I don't have experience, but if I have a pediatric patient who's requesting this, I would definitely offer it. And if it's my family, I would definitely offer it. I really think this is the future.
Dr. Beck, for pediatric patients, any special considerations? Do you still do local numbing medicine at the neck? Do you do sedation or anesthesia?
No. We also use the local anesthesia. The youngest people was 9-year-old because two young child is difficult to perform on the local anesthesia. One question from the audience is to Dr. Stephen Hodak. It's the second case. Molecular panel shows targetable mutation and the patient refused surgery. Would you consider RF ablation?
So the question is really asking if the shows that the tumor is a neoplasm, would I consider RF patient refuses surgery? I suppose I would consider it, though, depending on the, I would be more inclined to push the patient surgery if it was a more virulent, if you will, mutation, if it was something like a BRAF V600E mutation, or something that would portend aggressive behavior, I would be less comfortable doing RF ablation and would not feel that it represents the best definitive management. If it was a lower grade mutation, more like a RAS-like mutation of a low-grade indolent histologically follicular neoplasm, I think I'd be more comfortable doing RF ablation in that case. But I think that the jury's still out about whether RF can definitively treat neoplasia and guarantee that there won't be regrowth. And if that neoplasm is malignant and you're leaving malignant cells behind, are you opening a door to possible metastasis, especially in the case of a follicular lesion that's a neoplasm that might metastasize hematogenously?
Any other opinion? No? If no, let me introduce another question. The audience asked about the more aggressive pain control method. even deep cervical plexus block, superficial or deep cervical. What do you think about it?
No,
Candle?
absolutely no.
You,
There is no.
you don't like?
That's a crazy idea. Not painful. Patients can tolerate this very well.
Yeah.
But I think the other issue is if you're using adequate lidocaine around the capsule of the thyroid gland, you're effectively giving the equivalent of a cervical block by blunting all of the nerves at the distal end of the cervical plexus, or at least the relevant nerves. So it's really more a matter of are you getting an adequate amount of lidocaine around the capsule of the thyroid gland and sufficiently infiltrating in all of the appropriate planes.
So one question is, are a population with parathyroid adenoma? Do you have experience?
So I don't. However, years ago, Dr. Paolo Mecari from Italy published his experience with 7 cases using HIFU, not RFA.
Yes.
And over half of these patients had vocal cord paralysis. If you do parathyroid surgery, first of all, experienced parathyroid surgeon can do this very safely. It can be done under local. The parathyroids can be out in 10 minutes. And if you do this operation, the nerve can be really like just hugging this parathyroid. I think it's a little bit dangerous. I would not offer it. You're really asking for trouble. If you do this operation, you know that we are not ready for this at all.
Dr. Kander prefer surgery. Any other experience? We have some experience with parathyroid regions.
You can do it if it's inferior, because the inferior one is more anterior and it's away from the nerve. The superior one is a little bit more posterior and it's hugging the nerve more. So if you have a parathyroid that's more anterior, then most probably away from the nerve, then it's safer. So you really need to look into all these details, but it is possible. I might eventually do it, but I have to make sure if I have to do it, it's an inferior gland that's a little bit inferior and all that.
I agree. I agree. In our experience, the primary parathyroid adenoma is much easier than treat secondary hyperparathyroidism, and intrathyroidal parathyroid is easier than outside one, and inferior one is easier than superior one, but large amount of hydrodissection is mandatory for treating parathyroid region. Thank you so much for your questions. And we discussed a lot of interesting cases. One answers from the audience. The doctor agree with the inferior parathyroid RFA is safer. Thank you. So it's time to close our interesting session. So thank you for your very nice introduction of your cases, and thank you for a lot of questions from the audience. Thank you so much.
Thank you, Professor Beck, and thank you to all of our invited speakers for making this case review and discussion a success. For everyone in the audience, we appreciate you joining us today. We'd love to hear from you. It would be greatly appreciated if you could fill out the short survey following this webinar to hear more about your experience. Also, there will be a short StarMed promotional video after this webinar for those who would like to learn more about our company. At this time, I'd like to officially close this webinar. We look forward to seeing you all sometime in the near future. Again, thank you. Bye-bye.
Thank you. See you.